guests and all of the residents and our esteemed faculty. We have a real rock star group of faculty on tonight for third space intraluminal endoscopy for the Resident Fellow Training Committee. This is Brian Davis from El Paso, Texas. So I like to say live from El Paso, live from Chicago, live from Duke in North Carolina, and even as far as Abu Dhabi, where it's 3 o'clock in the morning. So it's time to talk about a really fascinating topic. Third space intraluminal endoscopy is the biggest topic coming out of Digestive Disease Week. All of the gastroenterologists went in on the action, and our goal is to make sure that we continue a fantastic training paradigm with great educators on tonight to really talk about how surgeons should be in control of this innovation. Advance slide, please. So SAGES is your training hub for innovation, fellowship, collaboration, and your growth as a surgeon. Advance slide, please. The benefits of candidate membership as residents are that you get access to journals, special events at meetings, get to meet the leadership, and become eligible for fantastic mentoring programs. And I know that many of our guests tonight have been part of the research mentoring that has gone on through SAGES. Next slide, please. So SAGES mission and values and vision are all critical to innovation, education, diversity, and inclusiveness with real promotion of our educational platform. And I have been privileged to be directing these webinars since 2016 as a tremendous way to outreach to resident and fellows to gain more membership. We really do have an esteemed group that has learned at the feet of the masters. Our first speaker is the Jedi Master in Chicago at Northwestern, Ezra Teitelbaum, who had the privilege of learning per-oral endoscopic myotomy from Hiro Inoue from Japan. Hiro Inoue was like Bono from U2, traveled all over the globe teaching the thought leaders in surgery how to innovate in this third liminal space. Our next speaker for the evening is Herbert Hedberg, who trained with one of my favorite governors in SAGES, Mike Ujiki, and is going to talk about the Zenker's per-oral endoscopy at North Shore Hospital, and really welcome his talents and his experience. Our next speaker from there will be the Vice Chair of Innovation that just got recruited away from Mass General to Duke. It's Ozanan Meireles. He's going to teach artificial intelligence how to take all of our jobs as the founder of the Surgical AI and Innovation Laboratory. And he's going to talk to us about submucosal tunneling for endoscopic resection. And then I have my arch nemesis in the field of gastroparesis, John Rodriguez, all the way from Abu Dhabi to talk about why the gastric pylori myotomy is supposedly the best treatment for gastroparesis until the stomach stops working. So thanks so much for the commitment to education, training, and teaching this next generation. Dr. Teitelbaum, would you like to start us?
Yeah, thanks so much, Brian. And thanks for having me. I'm going to share my slides. Can everyone see my slides all right?
Looks great.
Okay, thanks. I actually have to send a text about a patient, but I will start in just a second again. Duty calls as always. All right, thanks everyone. Thanks for your patience. So my name is Ezra Teitelbaum. I'm a general surgeon at Northwestern Chicago. We were the third site, I believe, in the United States to do POEM for achalasia. So we've been doing it since 2010. Kind of learned along the way a lot, and I'll kind of tell you a little bit about that experience and how we do it now. These are my disclosures, not related to this talk. So I'm going to talk a little bit about achalasia, kind of briefly hit on the key pathophysiology and how we make a diagnosis, evaluate patients. talk about the treatment modalities other than POEM a little bit, go through POEM technique, show some videos, and then talk a little bit about kind of what we know from outcomes data, which is actually pretty good for a procedure that's so new. So achalasia is thought to be an autoimmune process as a result of a virus. And as a result of that, patients lose inhibitory neurons in the esophagus. So that results in two things. This is both with swallowing. The lower esophageal sphincter can't relax, and then the esophageal body can't peristalse. So this causes typical symptoms of dysphagia, regurgitation. Most patients have lost weight as a result of a decreased oral intake by the time they're diagnosed. And some patients have chest pain, more with spastic variants, but dysphagia and regurgitation are the two key symptoms. So every patient with dysphagia needs an endoscopy to rule out malignancy and mechanical obstruction. Then patients typically get an esophagram to kind of define the anatomy. We're looking to see if there's a concurrent hiatal hernia, diverticulum, how wide and tortuous the esophagus is. And then the diagnosis is confirmed with high-resolution manometry. So that proves the diagnosis of achalasia and also subtypes the patient into types 1, 2, and 3 based on the esophageal body. So all patients have a failure of LES relaxation. In type 1, there's no activity of the esophageal body. Type 2, panesophageal pressurization. And type 3 is spastic achalasia, which is a little bit different. We'll touch on in a bit. So these are the main treatments. Medication and Botox, I'll kind of go into a little bit later, but they're not very effective. So the three kind of standard first-line therapies are pneumatic dilation. That's a large balloon that's put down endoscopically to stretch and break the lower esophageal sphincter muscle. And then probably everyone's familiar with Heller. Usually that is combined with a partial fundoplication to reduce iatrogenic reflux as a result of the myotomy, and then POEM, of course. So this is a kind of complicated decision. You know, definitely I discuss all three modalities with all patients, and I'll kind of get into a little bit more the pros and cons of each and how we make this decision. So first, though, I wanted to just talk about how we actually do POEM from a technical standpoint. So this is the first in the series of third space endoscopy procedures. So basically, the third space is within the wall of the GI tract. So we're basically creating a space in the potential space of the submucosa. So the whole procedure takes place between the mucosa and the muscle in the submucosal space. And how we do that is we access the submucosa by creating a submucosal bleb, doing a lift with fluid. We create an incision in the mucosa, and then we tunnel all the way from that incision all the way down across the lower esophageal sphincter and onto the stomach. And then after we've done that tunneling, we cut the muscle, and I'll show some videos of that. And then lastly, we close it. And I put an asterisk here. We use a flip, which is a measurement device that I'll get into in a little bit, to kind of measure the efficacy, to almost to serve as a quality control for the procedure. And that's a standard part of how we do POEM, and many people do it. So I'll kind of go through each of the steps, show some videos, and explain how we do each of the steps. So here's submucosal access. So to orient, we're in the esophagus. We're looking at the anterior aspect of the esophagus, and we use the regular injection needle to inject blue dye solutions, just saline with blue dye, to create a bleb. And we're kind of taking advantage of the property of the submucosa that it can fill up with fluid, the same way a lift polypectomy is done. This protects the underlying muscle from injury and creates a working space. So then we use a cautery knife. This is standard monopolar cautery, same as you would in the bovie in surgery, to create an incision. And now we're actually seeing through the mucosa to the submucosa. And this is, we're clearing a space in the submucosa down to the mucosa. And eventually we're going to maneuver the scope through that opening. And you can see that there's a cap around that's attached to the front of the scope. And that's really the only way we can do these procedures. You can think of the cap as the retraction during surgical endoscopy. So now we've maneuvered through that mucosotomy, through the opening of the mucosa, and we're into the submucosa. So now, just to orient you, the muscle is on the top of the screen, and the mucosa is on the bottom of the screen, and all this wispy cotton candy fiber is the submucosa. So now we're using cautery and combination of actually blunt hydrodissection and cautery dissection to clear a pathway going longitudinally from proximal to distal. So we're clearing a space down the entire length of the esophagus. We go past the GE junction and onto the stomach. You can see that space really opens up. So here's the muscle on top, the mucosa on the bottom. We kind of think of this as a safety zone in between. And when we're cauterizing, we want to basically avoid injury to the mucosa. We're going to cut the muscle anyway, so we don't really care if the muscle gets cut. We want to avoid injury to the mucosa. So we're staying very close to the muscle and kind of just slowly tunneling. Now you can see we're closer to the lower esophageal sphincter, and it becomes a lot harder in this area because everything is kind of fused together. So that space, that zone of safety, is a lot closer. We have to be a lot more careful, go very slowly, and you can see that the distance between the muscle and the mucosa is a lot smaller. So when we get down here, we go slower, and we do a lot of hydrodissection, which you'll see in a second, to inject fluid to kind of open up that space more. And here you can see we're injecting. We use the needle, but we just don't extend the needle, so we're basically just using a catheter. And then we inject blue dye. The blue dye helps clarify the difference between the mucosa and the muscle, and it also just opens up that space with hydrodissection. So very important to kind of continuously inject over and over again with the blue dye. And here you can see that completed tunnel, really the whole length of the esophagus we can go. And then we go back into the true lumen. So now we're in the true lumen in the stomach, and we're retroflexing. You can see the blue dye on the gastric mucosa, and that confirms that we're beyond the GE junction and onto the stomach. And then we start the myotomy. So we use the hook electric cautery, or triangle tip electric cautery. We're kind of using it like a hook, like you would during a cholecystectomy. So here you can see really nicely the circumferential fibers and longitudinal muscle fibers, so the circular inner. And we do a selective myotomy of the circular muscles. It's really just to avoid pass pointing beyond the esophagus. At the end, the longitudinal muscles are splayed apart. So I always think of it in essence as a full thickness myotomy, the same you would do as a Heller. But when we're actually cauterizing, we're really only cutting the inner circular muscles. And those are the ones that really contribute to the pathology. And you can see because of the tunnel, we've completely separated the circular muscles that we're cutting away from the mucosa. So here the mucosa is below, but you can't even see it. So you're really not in any danger of injuring the mucosa as long as you go carefully. And now we're on the stomach, and you can see at the end of the tunnel, the muscle fibers become much more disorganized. So they're kind of interlaced. There's sling fibers, clasp fibers, these fibers that are at oblique angles to the longitudinal and circular muscle fibers. So it's a little bit more confusing on the stomach. That's kind of part of how we use FLIP to kind of calibrate when we've done enough myotomy. And then the last part of the procedure is just closing the mucosal incision. We do that with endoscopic clips. This is actually an older video before we had clips that could rotate or open and close. So it was a lot more cumbersome. Now there've been a lot of advances in the last 10 years in the clip technology. Now they can open and close, so you can take a bite, see if it's good before you deploy the clip. And they can also rotate very well, so it makes things a lot easier. So basically, we use the last clip as kind of a lever and push that down with the cap, and that kind of nicely brings the mucosa together. And that's the end of the procedure. So kind of during the procedure, I mentioned we are constantly measuring the distensibility of the esophagus using something called FLIP. So this is, if you're not familiar with this, a catheter-based measurement device. It has some similarities to manometry, but instead of measuring pressure, it's measuring distensibility or kind of resistance to stretch. So this is something that's abnormally low in patients with achalasia, and then we can measure it throughout the procedure. So we take a baseline measurement, we do our initial myotomy, and then we can extend the myotomy if the distensibility is still too low. So this has been found to actually correlate better with outcomes than manometry. And we showed that its use is associated with improved outcomes. So cases in which we used FLIP had better outcomes on average than those in which we didn't. So I think this is kind of becoming standard for POEM and other procedures where you have to calibrate myotomies. So our kind of routine practice after the procedure, we don't get any esophagram as long as we're satisfied with the closure. Most patients go home the same day. We do a kind of standard advancement for our foregut cases, 2 weeks of liquid and puree, and then 2 weeks of soft food. Iatrogenic reflux is definitely common. I'll get into that in a little bit. So our protocol is we keep all patients, regardless of symptoms, on PPI for a year. And then we do routine testing a year after surgery, which at our institution involves an endoscopy with FLIP, pH testing off PPI that would determine whether the patient needs PPI lifelong, an esophagram. And then we try to do a manometry. Patients hate it. It's mostly for research purposes, so often we relent and let the patients forego the manometry. So how do the outcomes compare for all these treatment modalities? Well, medications is pretty easy because they don't work. They're very poor efficacy and have a lot of side effects. So really, there's not much of a role for medication therapy. These are mostly non-selective smooth muscle inhibitors. Botox injection of the lower esophageal sphincter, it works not very well, but it does work. The problem is it's temporary, so it usually lasts about 3 to 6 months. And then it's less effective each time you use it. So this is mainly for extremely high-risk patients. Patient just had an MI, something like that, where you need to get them out a little bit, or they're just not a surgical candidate. So really the 3 main treatment modalities, POEM, pneumatic dilation, and Heller, are all very effective. And we actually now have randomized trials comparing all of them. So I'll go into that in a bit. So first, how does POEM compare to pneumatic dilation? The best evidence is from a randomized trial that compared 133 patients between POEM and then a staged 2 dilation protocol. The primary outcome was symptomatic success in 2 years, and you can see dramatic difference with POEM much more effective, almost twice as effective as dilation. There were 2 complications with dilation, including 1 perforation and none with POEM. And a meta-analysis separate from this showed that there's a 3% perforation risk with dilation. So this is very different than a through the scope dilation. It's much bigger. Much higher perforation risk. So this is really something significant. The one downside of POEM is that there was more reflux. So both more esophagitis and higher reflux on pH testing. So in conclusion, I think we can safely say now that POEM is much more effective than pneumatic dilation, and I think safer when you take into account serious complications. But there is more reflux, so that is a downside. So moving on to POEM compared to lap Heller with a partial fundoplication. There have been a lot of studies that have kind of evaluated recovery and safety. In general, POEM is a faster procedure, less complications, less length of stay, and a faster recovery. So the perioperative morbidity is lower with POEM. This was evaluated in a randomized trial as well, and less complications. It wasn't really powered to detect that, but it seems consistent with the rest of the evidence. And I think, one thing that we worry about is perforation of the mucosa with a Heller. You can see, in a Heller, the muscle can be very, very scarred to the mucosa. You're kind of scraping it off. And so there's a significant risk of mucosal perforation. I think there's also a higher risk of actually missed muscle fibers. This was a case I did actually in residency with Matt Soper, who'd done hundreds of Hellers. And we were using FLIP for one of the first times. And it actually wasn't until we inflated the FLIP balloon that we saw there was an obvious muscle band that we would have missed completely. And this is one of the most experienced surgeons in the country doing this operation. So this is as opposed to POEM, where we first separate the muscle from the mucosa. So this makes it much safer because then we have this zone of safety. So we're not cutting muscle right on top of mucosa. And we can also visualize each individual muscle fiber much, much better than we can during Heller. So I think both from a safety and efficacy standpoint, the myotomy is superior with POEM. And it's been 5 years since we had a mucosal perforation, and I cannot say that's the same for Heller. We've certainly had mucosal perforations in that time during Hellers. So how do they compare during efficacy in terms of efficacy? There was a meta-analysis that compared basically all series of the two procedures. And POEM, this is non-randomized, but POEM was more likely to improve dysphagia both at 1 year and 2 years, but both are excellent outcomes, much better than dilation. There was a randomized trial with over 100 patients in each arm that I alluded to, and showed excellent treatment success again at 2 years and equal between Heller and POEM. I think to me, though, the long-term outcomes, this is yet to be determined, very long outcomes for POEM, but that's really Heller's Achilles heel. This Mayo series is, great paper. They followed up patients out to a mean of 17 years, and there was a 50% failure rate for Heller over time. And, why is this? I think, this needs to be looked at a lot more. We don't really know the full story of why these patients recur years later. But usually we found that it's not a problem with the myotomy, and it's not a problem with fibrosis. It's often a problem of a hiatal hernia or a problem due to the fundoplication. Here's an example, a patient of mine who was 5 years out from a Heller at an outside hospital. They were doing great and then slowly had a recurrence of symptoms. You can see here on the esophagram, the G junction is wide open, but there's a significant hiatal hernia causing angulation. So we did a hiatal hernia repair and didn't have to do another myotomy. In terms of reflux, the same meta-analysis showed POEM had much more reflux. So this was a little alarming. But if you look into this data further, it's very biased by older studies in the meta-analysis, Heller studies, that showed very low rates of reflux. And these are mostly Italian studies from decades ago. So if you look at more recent data and US data, it paints a much different picture. And probably Heller with partial fundoplication in the United States with current weights, diet, et cetera, has more of about a 30% reflux rate. And this was kind of reflected in the more recent randomized trial where there was slightly more esophagitis with POEM, but they actually had identical pH studies with 30% in both arms being positive. So I think that's kind of more realistic in a contemporary setting. In terms of some special cases, type 3 achalasia, where there's this long spastic segment, Heller results in very poor results, especially in patients with chest pain. So the difference is POEM allows us to go much more proximally and extend the myotomy up to basically the thoracic inlet. And here you can see how far we went in a case of mine. And, there isn't great evidence for this part. Type 3 is very rare, but the one aggregate paper showed that there was a higher success rate with POEM. So I think this kind of just intuitively makes sense. So in summary, I think, now we have a boatloads of evidence, despite what insurance companies try to say. There's actually a CPT code for POEM now, so it gets through insurance almost always. We don't have to fight that battle anymore, fortunately. But foam is definitely an established first-line therapy for achalasia. It's extremely safe with low complication rates, and in most cases, a same-day procedure. I think we can safely say now that it's more effective and safer than pneumatic dilation. So I would say we rarely do pneumatic dilation as a first therapy. I think it has similar efficacy in terms of relief of symptoms and probably better safety than Heller. Easier recovery for sure, but somewhat more reflux. So this is a balance. I would say we now do Hellers for patients with hiatal hernias, patients with Barrett's who had reflux prior to developing achalasia and have Barrett's, or patients who are just very conscious of avoiding reflux as a risk. So there's certainly a role for Heller still. Thanks very much. Appreciate your attention, and happy to take any questions if we're doing it now or at the end.
That's an amazing talk, Dr. Teitelbaum, and you'll have an amazing simulation center and are leaders in educating in surgical innovation. And I'm sure you're going to be teaching this soon to residents and fellows and attending faculty. We'd like to hold our questions for the end because it's a great discussion, including use of intraluminal therapies to solve reflux after this occurs. Our next speaker, welcome Herbert Hedberg, just up the street at North Shore in Evanston in Illinois, to talk about the Z poem. Thanks so much for joining us.
All right. Please let me know if you can't see my screen. Just trying to get the presentation mode.
Looks great.
So, all right, thank you. Mason Hedberg, previously North Shore, now Endeavor Health. I'm a general surgeon focusing on foregut surgery, including surgical endoscopy. I do some bariatrics and robotic abdominal wall reconstruction as well. No disclosures. I thought we'd start just with some reviewing some basic anatomy here. So thankfully, Zenker's diverticulum is not as complex as achalasia. I don't have quite as much to talk about in terms of the preoperative and other considerations. It's essentially just helping this pouch resolve. So it happens in between the inferior pharyngeal constrictor and the cricopharyngeus. Tends to be this is the upper esophageal sphincter, which is failing to relax. This is a false diverticulum, so an outpouching of the submucosal and mucosal layers, but the muscles themselves are not part of the diverticulum. And I wanted to mention as well that there are these are all hypopharyngeal diverticuli. The Zenker's is by far the most common, which we just talked about, but they can happen below the cricopharyngeus as well. This lateral one is a Killian-Jameson diverticulum. I've seen one of them, and you can treat them the same way with the Z poem. So I wanted to include them here as well. This is the endoscopic view of what these look like. I don't like this diagram great because it shows this tiny little mouth. That's usually not the case when you encounter these endoscopically. So on the left is a Zenker's. So this is the cricopharyngeal bar here has failed to relax, and over time the pulsion pressure has created this false diverticulum. So this is the Zenker's on this side, the true lumen of the esophagus over here. So you can see it's, food and pills especially tend to prefer to go into the false lumen, and we'll talk about the symptoms that can result. This is a Killian-Jameson diverticulum, so a little bit different. You can see it's a little bit off to the side. That bar is not quite as prominent, and it's actually below the cricopharyngeus here. So again, false diverticulum image here is a very large Zenker's diverticulum. They occur in roughly 1% of the population, but we see more in men and in the elderly. You can imagine dysphagia, regurgitation, things will get stuck in that pouch and then come back out. And there's this classic pill dysphagia where they'll take a pill and the pill pops back out into their mouth. Also halitosis from things kind of being static within the diverticulum. Clinical risks associated with these, obviously aspiration. If things are regurgitated, you can always inhale them. Impaction and obstruction, you can see a very large one here that's compressing the esophagus. So you can't get obstructive episodes from these. With chronic stasis, you get bleeding and ulceration, and ultimately squamous cell carcinoma is associated with the Zenker's in particular. again, that's about all the clinical review I had. So I wanted to go into a little bit more of the history of how the operation has evolved over time. The original approach is open. You can just look at the dissection there. Obviously, there's some morbidity associated with an open approach. They would cut off the diverticulum and then sew the mucosa closed and sew the muscle closed. Then there was the transoral rigid stapled approach. This has a good, it's very effective, but it does have a higher recurrence rate than the Z-palm, and it's also limited by neck flexion. You really got to be able to put your neck back to get the rigid stapler in there, and elderly patients cannot always do that, so that was a problem. I've had one patient we did a successful Z-palm for. He had a stapled Zinkers done previously and an endoscopic laser septotomy. I had not even heard of this until I met that patient. And there's a very quick video I have that I think is worth watching because it's an interesting view of essentially what we do with the endoscopic Zinkers. And this is sped up, but you can see they're using a laser to do a mucosotomy, just like we saw with the palm with Dr. Teitelbaum. And you can already see the cricopharyngeus below the mucosotomy there. And then they're using that little spatula to direct the laser to cut the muscle. So a similar idea to what we do endoscopically. This is a very specialized procedure. It's not done in very many places, and the only literature I could find about it described having a 6-day hospital stay with enteral nutrition afterwards. So I think did not catch on. Then the Z-palm. So Dr. Teitelbaum made a great presentation describing the submucosal tunnel and how to dissect through the submucosal fibers. It's even a little more simple, and my opinion for the Z-palm, you essentially just make an incision right above the bar itself and then drill through the muscle. And I'll have let's watch a video for that as well. So it has been proven to be lower risk. There's a lower recurrence rate. It's not limited by neck flexion, and we tend to send people home the same day on a puree diet. I'm gonna go back to the videos here. Sorry, these Zoom bars in my way. Can't find them. There we go. So this is Dr. Inouye, and he does a great job showing this case here. So if I did this correctly, you shouldn't hear the audio. I'll just kind of narrate as we go. But again, you can see the Zenker's diverticulum itself on the left side and the esophageal lumen on this side. Now he's doing that submucosal injection, just like we saw in the last video for the palm. And the mucosotomy. And I'll tell you that the narration here is interesting. I was trained to make the mucosotomy in line with the muscle. It has, in my experience, has been easy to close with clips that way. Here, Dr. Inouye says it doesn't matter if it's transverse or along the muscle as long as it's long enough. So he says a small mucosotomy will tear and it becomes very hard to clip. As long as it's long enough, it doesn't matter which way you do it. You can see the blue dyed submucosal fibers there. And you can already get a glimpse of the cricopharyngeal bar right here. And what he explains is you don't need to quite do that submucosal tunnel that we do along the muscle before doing the myotomy itself. He just clears enough room to get the scope in comfortably, and then you just go right through the muscle, and you keep injecting on either side to keep the mucosa away. Again, these are all these procedures are about protecting the mucosa. So he's injecting, get that mucosa away. The muscle is very clear. And he's just going to drill right down. I hope you guys can see the video. I got a text message that somebody cannot. Betty, I don't know if you've received any messages, but I can send you the link if people can't see the video. So again, they're not making a tunnel per se, but just clearing enough away to do the myotomy. The question as you're going down is how far do you go? And looking at his picture on the left side here, what we tend to do is you put your endoscope down before you even start, measure the bottom of the false diverticulum. And as you're doing your myotomy, make sure you get at least that depth. So sometimes that may require taking some of the top of the esophageal fibers. There's a difference. It looks like you might be getting there now, starts to thin out. So he is through the cricopharyngeal bar, but if you don't go far enough, this mucosal defect will not flatten out and there will be a residual pouch there. So myotomy is complete. You can see it running all the way down. He's done this well beyond the length of the diverticulum itself. So now he's going to close the defect. I do like this technique he has, using the suction to kind of pull the mucosa together. You can see how wide that tunnel was before, but he got that clip on very easily. And I think we can jump ahead a little bit here. Yeah, that's essentially the end. So I think you understand they'll apply clips along the length of the entire mucosotomy here. Again, I hope that video worked okay for everybody. So possible complications, like any of these procedures, got to be vigilant of vessels you can encounter. Bleeding can happen in any of them. We always have these coag graspers that you can use to get bigger vessels ahead of time or help bleeding that happens inadvertently. Leak can occur as well. This is an image, a CT scan of a large leak after a Z-pome actually. One of these clips got dislodged and it went into the mediastinum. We tend to do about a week at least of pureed diet after the procedure, just to prevent these clips from getting dislodged. I think one, I brought this up in my technical points here, but what can happen is the larynx drops down and kind of pushes the scope to the side, and you're looking at the side of the myotomy. He had a really nice view in Dr. Inouye's video there, but sometimes it does seem like you're coming in at the side of this. It is important to try to get right in the middle of that bar. The clips can be harder to apply laterally. And then persistence as well. So I mentioned going as long as the diverticulum itself. We have some data from our own experience at North Shore Endeavor, where these diverticuli longer than 4 centimeters actually benefit from having an endoscopic plication where the pouch itself gets inverted and will prevent ongoing dysphagia after the Z-pome itself. I mentioned these first two here. The horizontal versus transverse I thought was interesting. Makes sense to make a large mucosotomy. You want to have an intentional incision that doesn't stretch out or get ripped, but becomes hard to close. We covered how far to go. And then redos, I've only done 2. I mentioned the one patient I had that had a stapled and laser procedure done before. And I had one that had a stapled procedure prior. Both I ran into staples both times and there was scarring. It was harder to get that lift before doing the Z-foam to make make the submucosal space very clear. I think I just was a little more lateral. Again, this might be why I'm thinking about that larynx bumping me out of the way, but I tried to kind of get under the scarring and towards the middle below the prior repairs. And it ended up being fine once I got under the staples, but it was a little interesting at the beginning there. And I believe we're holding all questions to the end. So I'm going to stop there.
Thanks so much for a great presentation and great visuals and great talk about being trained by Dr. Inoue, and I appreciate everyone. I think the group discussion will be exceptional. Our next guest is Ozanan Meireles from Duke as the Vice Chair of Innovation and the originator of the Surgical Artificial Intelligence Laboratory. Thanks so much for joining us. I really look forward to your talk. All right, well, we have a message that Dr. Meireles is on his way to start. And in the meantime, I think this brings up some great opportunity to start answering some questions and some discussion while I have Dr. Hedberg on the line with Dr. Teitelbaum. Both of you experienced direct training from Dr. Inoue, which must have been a fascinating experience. And I wonder if you can share some stories about the implementation of your learning curve under his direct training.
Yeah, sure. So I actually never kind of learned directly from Inoue. We interacted a lot at meetings kind of when this was all started, but my mentor, Eric Hungnes, went to Japan to watch Inoue do a couple cases before anyone had done them in the United States. And then came back and did, I believe that he was the third person in the United States to do one. So it was very interesting for me. I was actually a resident at the time. When I started as a research resident in the lab, he was on his sixth case. So I saw every case between number 6 and number 120. So it was very fascinating just to kind of see how a procedure evolves, how you kind of learn to do it when there's no resources, there's no videos, there's no textbooks, there's nothing. It was very collaborative. I mean, we would call people from other institutions all the time, kind of trade tips and tricks. Every time there was every SAGES meeting, Inoue organized a poem meeting to happen right before. There was just a day where people would basically present cases, show videos. And so kind of everyone around the world was learning how to do it collectively at the same time. The first 20 cases were a struggle for sure, because it was so unique. We weren't doing any third space endoscopy in any other procedure at the time. So it was kind of a total new way of seeing the anatomy, surgery. I think it did help to have a lot of experience doing Hellers. Even though you're seeing it from the opposite side, the anatomy is the same. You kind of know what to look out for, know this. I think in some ways it's easier for a surgeon. They know you can create pneumoperitoneum, a pneumothorax. You kind of know how to deal with all these severe complications that can happen, understand how to deal with bleeding if you need to convert to laparoscopy, or call thoracic surgery or something. So I think that having that basis in understanding the disease, the anatomy from a surgical perspective was very helpful. But anytime you do something new like this, there's going to be a learning curve, and the key is just to have a lot of practice. So we worked on models, explant models, did many procedures, not only the surgeons, but the OR staff at the beginning to kind of get facile with things.
That's a fantastic example of safe innovation. And are you teaching courses at Northwestern at your simulation lab? It's a beautiful simulation lab, by the way.
Thanks. No, we haven't done standalone poem courses, But you know, I've been faculty in a lot of courses through SAGES. So that's a good place to start. Usually most SAGES meetings every year will have a hands-on lab. And then there's a couple other institutions that have really good hands-on labs. I think University Hospitals in Cleveland has been doing them, where I did fellowship, Oregon Clinic in Portland, and then I think Mike Ujiki at North Shore in Evanston has been doing them as well. Those are the ones I know of. All would be, you know, fantastic places to kind of get some hands-on experience.
I think one of the most interesting things is that the complications that do occur, as you said, pneumoperitoneum can happen safely without a problem. Pneumothorax can happen safely. But if you clip off the mucosa, place the patient on antibiotics with proper monitoring of those spaces, most of these perceived complications tend to heal after 3 to 5 days in the hospital.
Yeah, we fortunately never had a pneumothorax. That's pretty rare. So we have not had one in 400 cases. Pneumoperitoneum is not infrequent. We used to decompress it with a Varus needle, like whenever we would find it, intra-procedure. So we, you know, suck out the stomach. There would still be the abdomen would be tympanic. We put in a Varus needle. Now we've kind of moved away from that, unless the patient's extremely distended. Usually we don't need to decompress the pneumoperitoneum. If we get an upper GI because we're concerned about the closure the next day, often we see pneumoperitoneum, and you know, it's of no consequence. You know, very important to always use carbon dioxide insufflation, not air, so it's rapidly absorbed. And usually patients, you know, have maybe a little bit more pain, but you know, no adverse you know, physiologic consequences.
I do apologize to not mentioning this to our audience. You can go into the chat box and present questions, and we're happy to present the questions to our two present speakers tonight. One interesting point would be, is there any noticeable difference between endoscopic suturing and clip closure for treatment of that mucosotomy?
I'll say it's hard to do it for the Zenkers. It's, you know, it's a tight spot. It's be a little bit of scope trauma trying to do that, I think. In my experience, I've actually never used it to close the mucosotomy for a palm. I find the clips are adequate. And again, it's, you know, another scope exchange, a lot more equipment, and a little more cumbersome than the clips.
Yeah, same. The only time I've ever done suture closure was during fellowship, just for practice. But you know, you know, a huge advance in the technology of clips. I mean, I can't overstate how much easier it is now than it was in 2010 when we started doing this. And now they're even, you know, wider clips where you can bring one side, grab one side, move the scope over, go to the other side. So that's made the closure, you know, much easier. But you know, whenever you're doing any kind of third space or full thickness transluminal endoscopic procedure, it's always good to have suturing available in case you need it.
I can imagine. Another question I have is, in training, it seems fairly common where at the distal part of the myotomy, there's an attempt to have some spiraling that occurs. And you'll have any tips or tricks to prevent spiraling in that third space?
I mean, my keep your horizon steady. You know, I'm always trying to keep the, you know, once I get my orientation going down that tunnel, you keep it the same way as you're getting into the tight spot. And I think as long as you're doing that, it's going to be relatively safe.
That's a great tip. Thanks so much for the discussion, gentlemen. Dr. Ozanan Meireles is ready, and we appreciate him joining us despite his multiple commitments at Duke currently. Thanks so much for having this talk with us.
Thanks, Brian, and I appreciate you guys waiting for this. We're receiving the would you guys see? Let's see here. Do you guys see my? Yeah, perfect. Yeah, excellent. So I just have like several visits here today, and like I was just trying to time myself, but I really appreciate the opportunity to speak to the residents here today. I think this is super important. I always found SAGES to be a amazing platform for us to learn and to interact with others who have been pioneering flexible endoscopy. And I'm a truly believer that flexible endoscopy is the next frontier in invasive surgery, especially as we explore the third spacing. So talking about endoscopic submucosal resection, it is super important to understand that this was modeled after POEM, right? I also had the pleasure to be trained by Haruhiro Inoue in Tokyo, in Yokohama, actually, when I was in my fellowship at UC San Diego. We went over there, and the guy is fascinating. He literally trained the entire planet. So the very first endoscopic resection of an esophageal submucosal tumor was done in 2012, about 2 years, like 2 years after when POEM started being performed. The indications are for benign tumors like GISTs, leiomyomas, and some esophageal submucosal tumors, such as lipomas, granular cell tumors, and some cysts as well, and some select neuroendocrine tumors and schwannomas. There has been report of people also attempting to do those procedures in other parts of the GI tract, including the colorectal area. But normally they do this not for address a tumor that's subepithelial, but to do tunneling and allowing them a better excision of the mass. Contraindications, think about an ability to tolerate endoscopy. Poor surgical candidates in general. Why is this? Because if you think about they're going to be resecting mass on the esophagus, there might be full thickness. If you get into some complications and you have to go under like thoracoscopy or thoracotomy and the patient cannot tolerate that, it should be a contraindication for removal of the masses endoscopically as well. Lesions larger than 5 centimeters. I'm going to show a case here that actually was a larger mass. It can be done. You may have to do piecemeal, but you have to be very mindful because you might be leaving some margins behind. Invasive or malignant tumors, just because you won't be able to have a good control of the invasiveness, even if it's benign, from if you have any bleeding or any other major complications. Of course, malignant tumors shouldn't be doing this. And of course, any coagulation disorders like in any endoscopic procedures. The diagnosis is made in general for patients have some vague symptoms, could be from dysphagia, could be from regurgitation, and end up getting an endoscopy, and they find to have a mass. The majority of those symptoms are arising from the esophagus, but like I said, some of those masses could be in the stomach as well. In general, after the endoscopy, a CT scan is done, which shows the mass, and then it's ideal to get an endoscopic ultrasound just to show what are the level of relation of the mass to the muscular proprias and around structures. So the procedure is, I can be depicted on this image here. It's similar to POEM, like I said, you make a mucosotomy, you develop your tunnel, you dissect around the mass, you excise the mass, and you close with clips. So here again, just to illustrate, and I know the other initial talks on both POEM and Zenker, they were illustrating the similar techniques. And if you can see here, the lifting of the submucosa, dissection of the submucosal tunnel. Here we will be going around the mass, and of course you're going to be closing that with clips. So again, step one, the access is very similar to POEM. The only thing I would say is like POEM, sometimes you do the myotomy, the longer length of a longer tunnel before you do your myotomy. Here you want to be a little bit closer to the mass. Second thing is your tunnel will be larger on the submucosal tunneling because you have to dissect around the mass, and I'm going to be showing the entire case. And the closure might be a little bit larger if you'd be removing a larger size of the tumor. All right, so let's go to the next one here. So I'm going to take you to the case, and I think I'm going to keep the narration here just because it was a pretty good case that was presented by one of our fellows back at SAGES. There was a very interesting case.
Submucosal tunneling endoscopic resection of an esophageal leiomyoma. The patient is a 50-year-old female who initially presented with melena. During workup, she underwent an upper endoscopy, which revealed a submucosal mass in the mid-esophagus. On endoscopic ultrasound, the mass was well circumscribed and arose from the muscularis propria, measuring 3 by 1.5 centimeters. Pathology revealed smooth muscle cells consistent with a leiomyoma. Cross-sectional imaging revealed an esophageal mass at the level of the carina without local invasion. The patient was offered surveillance endoscopy versus excision, and she elected to undergo resection of the mass.
Just one comment here, two things. One pearl is that even though she had an endoscopy done, you as a surgeon should be doing your own endoscopy as well, so be certain where you're going to be dealing in the OR. Second thing, she was also debating if she would like to have thoracoscopic approach. Was a pretty high mass, and it was a little bit more challenging because of the nature of being more proximal.
She was taken to the operating room for endoscopic resection of her esophageal mass. Initial endoscopy revealed normal stomach and esophagogastric junction. The submucosal mass was located 25 centimeters from the incisors. We chose a spot on the esophagus that was 5 centimeters proximal to the leiomyoma and 20 centimeters from the incisors. The area was irrigated with facetrazine solution, and then a submucosal wheal was created by injecting methylene blue dye.
I like to make my mucosotomies longitudinally because that's how I like to close the clips. You can also make transverse if you're planning about suturing disclosure. The second thing is her esophagus is not dilated like those achalatic ones that you can spiral, so it's less likely that you're going to be missing the mass. But another pearl would be that you should also do some injection of the blue dye just above the mass, so as you're going to the tunnel, you can identify the right location.
A longitudinal mucosotomy was then created using the triangular tip knife. A submucosal tunnel was created. The mass was dissected free from the surrounding tissue between the mucosa and the muscular layers using the TT knife and electrocautery as seen here.
So here it's important to maintain your pneumotunnel. In other words, means if you are if the mass is extending beyond the esophagus, you will start resecting that. You're going to start having much more extravasation of the CO2 into the mediastinum, causing pneumomediastinum, could cause pneumothorax, and all those complications. So trying to keep this as contained as possible until you go around the mass is very important.
In order to facilitate keeping tension between the mass and the esophageal muscle fibers using the tip of the endoscope cap, the pedunculated portion of the mass was excised in a piecemeal fashion using snare electrocautery and extraction from the submucosal tunnel in multiple pieces.
We decided to do this for a few reasons. One is it was not an achalatic dilated esophagus, so don't have a lot of working space. And for us to be able to work around this mass and to see where was extending, and we knew from the ultrasound that was pretty much close to the wall of the esophagus. We elected to start resecting in a piecemeal fashion.
Once we had completely excised the pedunculated portion of the mass, we could clearly see that the base of the mass arose from the muscularis propria and involved the full thickness of the muscular layer. A full thickness incision into the muscular layer was created using the TT knife. We can see the mediastinum beyond the tumor here. In order to maintain tension and traction during excision of the tumor base, we elected to snare the tumor. A snare was thus passed through the working port of the endoscope and used to snare the base of the tumor. The endoscope was then passed over the snare and then reintroduced alongside the snare. Submucosal tunnel to the muscularis propria
Sorry about this.
to snare the base of the tumor.
So to explain here, what we did was we needed to have a better way to do some contratraction. But because the snare was occupying our working channel, and also was within, as we moved the scope, the snare was moving as well. We snared the base of the tumor, and then we cut the snare from outside with the handle, and so we kept like a callus just maintaining the pressure, and we brought the endoscope out. So then we were able to take the snare, release the cali, get the snare out of the endoscope, and then we pass the endoscope back into the esophagus. And then what we had was an endoscope with a free working channel for us to use whatever we want to use, and a snare running in between the esophageal lumen and the endoscope as our contratraction. And that worked very well.
Produced alongside the snare, while tension on the snare was maintained per-orally by an assistant. With extra tension maintained axially on the tumor base by the snare, dissection was now greatly enhanced, and we were able to more easily dissect the mass free from the muscle fibers. The tumor was extracted, and the mucosotomy was closed with endoscopic clips. The patient was awakened from anesthesia and extubated without issues. She underwent a swallow study on postoperative day 1, which showed no leak from the mucosotomy. She was started on a clear liquid diet and was discharged that day. Her final pathology confirmed a leiomyoma.
So, so what I would say about this technique is like you have to be resourceful. No, not every single case is the same. Different than like if you have done a lot of poems, they are always like they could resemble one another, like dilated esophagus, not so much, tortuous, so on and so forth. You can get a sense. But those masses, depending what they are, you have to play with the position of the patient and the gravity, be resourceful about using other tools. Some have reported utilization of two endoscopes, like a pediatric one and another one. Full thickness resections are possible, such as this case, as long as you have a good flap. You have to be cognizant about the potential complications, which include all the others similar to poems and the Zenkers. There is a chance of recurrence, like any one of those tumors, so surveillance is recommended. And there is a few papers, a few meta-analyses published, but they are kind of far a few and in between, but they all show good results, and with the techniques that you acquire by doing POEM, you can extrapolate to this type of procedures. So I just want to touch base about something interesting, since like my field of research has been in artificial intelligence for the last 7 years, that we can start thinking about how could we start enhancing our perception and our knowledge for intraoperative guidance for procedures such as POEMs and endoscopic resections. We didn't do this type of study on the submucosal tunneling for mass resections, but we did this for POEM. And the interesting thing about to know is this: if you look at this image here, you have it is a log probability of the sequence of the events to be occurring in the right fashion. And this, again, is a visual representation of this log probability. And we call them surgical fingerprints. You have these steps of the procedure right there. And then red is the ground truth, means the humans who actually annotated those data sets. And the light purple, the blue, is what the machine understood that. After we trained the machine some use cases, the machine was then later capable to make the determination if it was a straightforward procedure or if it was a tortuous esophagus, right? We kind of stop over there. We were not able to really find the complications, the bleeding, the things were leading, maybe because of the data set. But imagine that we can start extrapolating this to the point we can actually be understanding if you go too deep, you shouldn't be doing this because you're going to be losing your pneumo tunnel. You might be going too close to the mucosa. So that's where some of the potential aspects that we see on this. And then we saw that every time there was a deviation of the norm of the operation, you have a low log probability. And the other way to represent this is the machine was able to see what was normal, what was abnormal, was not able to tell us not to go there or not, but at least to tell us that something happened that was abnormal on that sense, right? So that was my talk. Thank you very much, and looking forward to answer questions.
That was an amazing talk, Dr. Meireles, and I really love the artificial intelligence, because I think for our audience, the big question is how to climb this steep learning curve and really have confidence in implementing innovation. And the introduction of your technology really will help many graduates adopt this novel technology. So our next speaker, I hope, will be John Rodriguez, who should be with us from Abu Dhabi. Is he on the call with us?
Good evening, everybody.
Thank you so much for joining us.
Thank you for the honor of the invite. It's really a great opportunity for me to join and kind of share some of my experience with you guys. I'm trying to start my video here, but I think it has to be started by the host.
Your children in sunglasses is a great look.
Yeah, let me see. I'm not sure. Yep, I think it says host has disabled it. There you go. All right. So we're going to switch gears a little bit, and we're going to start talking about gastroparesis. I'm going to share my screen so I can share my presentation. Perfect. Okay. All right. So can you guys see my screen?
Yeah, looks great.
Yes.
Okay, perfect. All right, so thanks again for the honor of the invite. And we're going to be talking about now third space endoscopy in the area of the stomach and functional motility disorders. So my disclosures are listed here. None of them are relevant for this talk, except that we do have an NIH R1 grant called the MTS trial for investigation of oral pylori myotomy for gastroparesis, which is currently ongoing at main campus in Ohio. So the take-home points that I want everybody to get out of this is to understand a little bit about the diagnostic workup of gastroparesis, which I think is one of the challenges for this disease. Talk about the role of gastric emptying procedures, specifically endoscopic pylori myotomy. And one of the big things that I think plays a huge role in the way that gastroparesis is treated is the role of the multidisciplinary care team for this condition. So gastroparesis is actually the second most common sensory motor disorder of the GI tract. So it's actually, a real epidemiological problem, both for patients and for the healthcare industry. It has a very high incidence of coexistent medical conditions. And as we know, for those of us that have been involved in the treatment of this disease, is that it's a very complex problem to treat. And part of the reason is that patients that present with gastroparesis had a very high incidence of chronic pain and narcotic dependence, which makes it very challenging to set expectations right. Those that are diabetics tend to have poorly controlled disease. There's a lot of coexistent complex comorbidities, and patients come in a way with unrealistic and high expectations for cure, which, as we know, it's something very difficult to achieve with this condition. When you look at the impact it has in the healthcare industry, about 1.8% of the population in the US, and this is data that's, at least 10 years old, are affected by gastroparesis. And looking at the diabetics, 14% of those with type 1 diabetes will present with symptoms of gastroparesis at some point in their disease, and almost 10% for type 2 diabetes. And when you look at how these patients do over a 5-year period and you look at their survival, it's significantly decreased when compared to a matched cohort. Now, one of the things that has changed the treatment of gastroparesis in the last 10 years is that understanding the role of the pylorus in a disease that is overall very poorly understood has changed the way that we target our treatment strategies. And there's been some studies that have looked at manometry describing a pattern of pylorospasm in patients that have gastroparesis. And we know that the way that the pylorus functions is a huge effect on antral and duodenal motility. Some studies that have looked at histology have shown that there's depletion of the interstitial cells of Cajal and fibrosis in those patients presenting with the disease. So one of the questions I think that we really need to standardize a little bit, and even though the diagnosis is not universally accepted, I think for most of us, we know that a 4-hour gastric emptying study using a solid meal and non-extrapolated data is probably the best and most universal way to diagnose the condition. But in the last few years, we've seen new technology like the use of wireless motility capsule as one of the most useful tests to look at not only gastroparesis with patients with other dysmotility disorders of the GI tract. And with our experience in at the main campus, when we looked at our first 1,000 cases that had smart pill, the interesting thing is about 33% of the patients that had a wireless motility capsule had isolated gastroparesis. And what we were seeing is that there were a lot of patients that had not only gastroparesis, but also some degree of small bowel and colonic dysmotility, which affects the response to treatment for these conditions. And this is what a typical report looks like when you can see, based on the data obtained by pH and pressure waves, that you can kind of get a pretty accurate estimate of how long this pill is spending in different parts of the GI tract. And when we see these patients in clinic, one of the common tools to assess the severity of disease is the GCSI, or Gastroparesis Cardinal Symptom Index, which is it's based on 9 questions with a score ranging from 0 to 5 that kind of tries to understand the disease in terms of 3 subdomains: the presence of nausea and vomiting, fullness and early satiety, and bloating, which are some of the most common bothersome symptoms. And this is kind of what the table looks like. So when we look at how pyloric interventions have changed the disease, what we're going to be talking about mostly today is per oral pyloromyotomy, GPOM, or it's another common name for this procedure. And what we have seen in the last 5 years is that for gastric emptying procedures, there's a lot of growing evidence. And it's one of the few interventions where data shows improvement in gastric emptying half times. So it has really become an accepted first-line therapy despite some recent controversy. And I think that one of the first publications that really shed a lot of light into the role of the pylorus was this coming out of Lee Swanstrom's group, looking at about 177 patients over a 5-year period that underwent the laparoscopic pyloroplasty. And of those patients that were able to follow up and had gastric emptying studies done after their operation, they saw an 86% improvement in their gastric emptying half time. This was something that hadn't really seen before with any other intervention to this date. And as it's the natural evolution of our field, is that we have always moved into ways to make these interventions less invasive and easier to tolerate for patients. So it's a history of open surgery to minimally invasive surgery. And what I think is probably the most exciting advancement in minimally invasive surgery in the last decade, which is third space endoscopy or intramural surgery. So looking at peroral pyloromyotomy was initially described in a porcine model in the early, in 2012, with the first human series following a few years later in 7 cases, where they also found significant improvement in gastric emptying studies. So we became very interested in this technique, and we established it as a primary therapy for gastroparesis in early 2016. And we've been able to accumulate a pretty wide experience in our enterprise with over 1,000 cases to date. We maintain a prospective database under IRB. Every patient that has this intervention has a multidisciplinary evaluation. We use GCSI in all of our patients preoperatively and postoperatively, and we also use 4-hour solid protocol gastric emptying studies. We've been trying to establish wireless motility capsule as a standard of care, but unfortunately, we do face quite a bit of challenges with insurance coverage up to date, so we keep it as an optional part of the workup. And when we looked at our first experience with the first 100 patients in this study that we published a few years ago in Annals of Surgery, what we found is that 78% of those patients that had gastric emptying study after their procedure had significant improvement in their gastric emptying times. And when you look at the severity of their symptoms, they also had a significant improvement in their subjective scores based on GCSI. And looking at the data that has been coming out over the last 5 years, this is a systematic review that was published a few years ago, looking at about 292 patients with 100% technical success. And I think, again, the reproducible nature of this procedure showed that there's symptomatic improvement in about 83.9% of the patients, and also a significant improvement in their gastric emptying times. We compared this to our laparoscopic counterparts. Sorry, I had a video here somewhere that didn't show. And what we found is that we had equivalent results, but we were able to do an endoscopic intervention in less time, with less blood loss, and a lower risk for reoperation that we did in our laparoscopic group. So interestingly, we looked into ways to validate this procedure, and we were very fortunate to obtain a grant from the NIH, which is currently undergoing at main campus. But in the meantime, this was published a couple of years ago out of Jan Tak's group, which is a very similar protocol than what we're currently doing, which is looking at endoscopic pyloromyotomy versus a sham study in a randomized fashion. And what this group found is that the patients that underwent endoscopic intervention had a significant improvement in both the subjective score based on GCSI, as well as a gastric emptying study. And this group, this study actually was stopped by the IRB in this institution because of this dramatic change, and they were only able to enroll about 41 patients. So the challenge that they had is that it was an underpowered study to really look at all the subgroups of gastroparesis. So they really only showed the improvement in the diabetic subgroup, but was underpowered to look at patients in the idiopathic or post-surgical groups. So looking at how we approach these patients, the way that we try to navigate the proper diagnosis and hopefully have a somewhat standardized protocol for care is based on a combination of symptoms and objective testing. So when patients present with not just foregut symptoms like nausea and vomiting, but also complain of constipation and severe bloating, those are the patients that we really try to push into wireless motility capsule before we make any kind of decision about their intervention. Once the diagnosis is confirmed, we try to start always with a medical trial using prokinetics. Some patients with autoimmune disorders, we have a protocol for IVIG, and we also, our colleagues from GI had an ongoing study looking at domperidone, which, as we know, is regulated in the United States, but available in other parts of the world. And those patients that are in the diabetic category, we make a huge effort into trying to optimize their glycemic control. We see a lot of these patients that have very severe nutritional deficiencies, and those patients, I think, we consider them for enteral access, whether it's temporary or long-term interventions via nasojejunal feeding tube, or in some cases, endoscopic or even laparoscopic feeding tubes. And those patients who are diabetics and who have obesity also go into a bariatric pathway, because as we know, bariatric surgery is also a big part of the treatment for these patients. But those that are not, or those that unfortunately are not candidates for bariatric surgery, usually a gastric emptying procedure endoscopically is our first-line therapy for most of these patients. And then, I like to think of it as a step-up approach. So as we know, the response rate for all these patients, unfortunately, it's not 100%, so some of them will fail. And that's when other strategies become useful, like gastric electrical stimulation, or even in some patients, gastric diversion or gastrectomy. So in summary, gastroparesis is a very challenging disease. And I think one of the big things that I really learned is that it's not something that you want to tackle on your own. Get a group together. I think that a critical component is having, a good surgeon, a good gastroenterologist, psychologist, nutrition, and also some ancillary services that are very important in some of these patients that come with quite a complex array of disorders. Gastric emptying, I think the data shows that it should be considered first-line therapy, and specifically with the endoscopic techniques, I think the advantages have been described, even though the evidence is still growing. This approach is very safe and effective, and as we have seen in some of the publications out there, it outperforms laparoscopic pyloroplasty in terms of safety, complications, and length of stay. Patients that have other conditions like diabetes and obesity, bariatric surgery should be a big part of the armamentarium. And gastrectomy for some of these patients is a good end of the road procedure when everything else fails. And hopefully we will continue to see more level 1 evidence show up in the near future. So thank you again. I'm sorry for some reason the video didn't show, but I'll be happy to take any questions.
That was a fantastic talk. Dr. Rodriguez, thanks so much. I'd like to tell everybody in the audience, please submit your questions through the chat box. We also have a survey that we can complete that has been placed in the chat box on SurveyMonkey. We do appreciate your feedback and your contribution to SAGES and your consideration of joining our membership. And I do have a special challenge for Dr. Rodriguez in presenting level 1 evidence. And I was just at Digestive Disease Week with your colleagues from Cleveland. And that is, I presented what my mentor, Dr. McCallum, designed as the level 1 randomized controlled trial. And I believe the next step is for the leaders in endoscopic myotomy to look at a combined gastric stimulator and endoscopic myotomy on a randomized trial by our design to really determine what are the long-term effects of each individual selective procedure. Any comments about my challenge?
Yeah, so I think that it's a very interesting challenge, I think, because I think when you look at the way that we have been treating gastroparesis for the past 10+ years, we have been doing things that have not been strongly supported by evidence, right? So even when you look at the data for gastric electrical stimulation, and there's been a couple of randomized trials looking at it, the data is really not that strong. And I think that that's one of the challenges when you're dealing with a chronic condition like this that is severely debilitating for patients, where we're trying to do our best to help from a surgical perspective, from a medical perspective, and we really lack the instruments to have a significant impact in the care of our patients. So, I think one of the challenges that I've seen with this patient population is really the lack of support. When you look at the vast majority of patients that are treated for gastroparesis in the United States and even abroad, it's in these isolated groups of, they see a surgeon who puts a gastric electrical stimulator, who doesn't really know how to manage it, treat it. They have never seen other members of a team that may help them address some of their other medical conditions. And these patients lack proper follow-up. So I think that, what we have seen in the last few years that to me has been the most significant impact in the care of gastroparesis patients, more than any isolated procedure like, per oral pyloromyotomy or gastric electrical stimulation or whatever we're doing, is that people are starting to understand that this is a very complex disease that you have to treat as a team. And patients are being offered resources that they didn't have access to before. And I think that this is really what makes a big impact in the care of these patients. So I think as we try to standardize care, and we're still a little bit divided into what the first-line therapy should be, whether it should be gastric electrical stimulation or it should be gastric emptying studies, I agree with you that we need to kind of work together to build the trials that will show who benefits from what and what is truly the proper strategy for each individual patient, not only based on etiology, but also depending on their access to care, right? Because, I do see a lot of patients that, had gastric articular stimulation done. And, when I was in Ohio, between ourselves up in Cleveland and our colleagues in Kentucky, we were putting a lot of gastric stimulators in. But then these patients had a really difficult time following up at the proper interval, so we could keep track of their stimulators, adjust their stimulators, and we were losing these patients to follow up. So I think that I'm not sure we have the data to say what the best strategy is. I think at least in some of the groups that have adopted gastric emptying study procedures, mainly pyloromyotomy, I think the data has shown that it is a very safe and effective therapy. So I don't think the cast has set yet. So we'll see what happens in the near future, hopefully.
Just to recognize the productive debate, you and I debated this in 2021 for the Virtual Sages Hot Topics, and we agreed that your patients are mostly outpatients and that mine have trouble leaving the hospital because they can't stop vomiting. And that the trouble is we can't really stage gastroparesis accurately, and there's such an underserved population that it's very possible we learn to stage the disease, that the endoscopic pyloromyotomy should be first line for people that still have some emptying, followed by further interventions like gastric stimulation for those that can't seem to stop vomiting. And that's why I think it's a very interesting challenge. I do wholeheartedly support implementation of the technology in what you're describing as the Cleveland Clinic model, where people have access to a large team of skilled interventionists that follow the patient. And we do know those patients from Kentucky by Tom Abel don't tend to have quite the exacting follow-up that your health network provides. And I appreciate that insight. I'd like to open up for group discussion. There is significant concern that gastroenterologists that may not have Dr. Rodriguez's team-based mindset are going to adopt these procedures, implement them without good standardization. So one of the big topics at Digestive Disease Week was, if we don't use EndoFlip to determine our success and our outcomes, we may not be accurately finishing the procedure and providing follow-up outcomes. And I know that many of our other speakers, like Dr. Teitelbaum, use EndoFlip. We've brought that up in discussion. And I want to see what the group thinks about how we really look at standardizing our outcomes by using common measuring tools.
Would you mind if I start?
Please do.
I have opinions about the prior discussion and the current. I'll be brief on the prior, but I have a early practice in implanting gastric simulators. I've done 4. The approach I have for gastroparesis, I agree. I think there is a mechanical problem. Opening the pylorus helps. If there are symptoms that persist, especially nausea, the stimulator is a great option. The patients I've had, like I said, 3 of them said their nausea is 80% improved, and they've stopped throwing up every day multiple times because of it. So I think it is a great tool. We don't completely understand how it works yet. There are some recent studies showing the full thickness biopsies after 6 months. There's some regeneration of the myenteric plexus. It's doing something. And I think it's interesting. I agree you need close follow-up and a good system to help, engage these patients. But
that's my group showing the cells for call come back. So with reduction of inflammation, a decrease in cortisol from the vomiting, the cells regrow. And not to brag, I took those biopsies.
Recent research. I should know my names better.
Okay.
Well, that's fantastic. And then for Flip, I also have opinions. So I work with Dr. Ujiki. He kind of pioneered a lot of the usage of EndoFlip in foregut surgery in general. One thing that's interesting, and I'm curious to see what everyone else thinks, but there is a wide variability of normals, right? It's hard to really pin down exact values that can be in a normal population, especially when this is using the pylorus. There's only a few studies out on that, and they're very variable. So the utility really seems to be, can you determine the adequate myotomy? Here's the starting distensibility index. The EndoFlip says this before you start. And then after you're done your myotomy, has there been enough of a delta? Has it increased enough? That's how we use it primarily. We have a big database trying to look at these normal kind of values. Like if it's over this, is this adequate? Is it going to cause GERD? If it's too high, things like that, we still don't know. But I do think the utility is good for determining an adequate myotomy. Can you do these procedures without it? Absolutely. There are visual cues. I think it helps in the learning curve when you have a number you can look at to see what you're doing. But it's not a necessity. It's an extra tool we have.
Excellent response. In the topic of whether the gastroenterologists are going to take over, I know Dr. Teitelbaum mentioned that the surgeons have a natural advantage of knowing both sides of the lumen. Any other comments from the group?
I want to say something about like gastroenterologists versus surgeons, right? And it kind of like depending, like as we're evolving as like endoluminal surgeons, like we kind of have that tendency, like we can do this better than the gastroenterologist, or like we can do this, like can take care of the patient better than so on and so forth. But what I learned through my last 14 years practicing, that I met some gastroenterologists that they take care of the full spectrum of the patient. And I met some surgeons, they are proceduralists. So I think the most important part of it is like how we can, and I don't fault them because that's how they practice it. If there is a proceduralist, they're so good about what they're doing, but then there's going to be somebody else going to be taking care of the patient, right? I think it is a longitudinal thing to think about it. How can we structure a system that's going to take care of the patient, right? And then we can plug those people in. But unfortunately, this you can only find in very large academic centers or like big hospitals. And when you go more to a smaller practice, underserved areas, you won't be finding that. So that's one thing. And one comment about the flip, I think the flip is excellent for when people are learning on the beginning, because you don't have that visual perception and the intuition, and those numbers really help you too. Can you do without the flip later? I think you totally can. But I think it really helps to expedite the learning curve.
Yeah, I wanna piggyback on what Oz just said, because one of the things that I learned in the surgeons versus GI debate is that I think when you look at panels like this and people that have been very fortunate to either train or work at institutions where surgeons have been pioneers in surgical endoscopy, it gives you a little bit of a biased view. But when you go out into the real world and you look at this debate not from a physician center but from a patient-centered perspective, I think that when you actually get the two of them together, you achieve way more than when you look at us separately, because most institutions out there don't have a surgical endoscopist or have a gastroenterologist who is able to start a third space endoscopy program on their own. So I think when you really get the teams to work together, what you can achieve for the patients is way better than when you look at us independently. And when we started opening our doors in Cleveland, we would come and learn some of these techniques, whether it was poem or pop or stir or whatever we were trying to do. The teams that were the most successful were the teams that came together and identified a member of a GI team and a member of the surgical team and build the program together and made it progress together. So I think that out there in the real world, where it's very difficult to see these procedures in silos, getting both of them together and looking at it from a patient benefit goes pretty far.
Great responses. I do want to bring up a very interesting innovation point through SAGES. Through these SAGES Adopt courses, simulation models are sent out to practicing surgeons outside of great centers like Cleveland Clinic and Duke. And then there is a practice of telemedicine or teleproctoring. Like Dr. Rodriguez and Dr. Meireles has said, these disparity environments may not have a great understanding of manometry, endoflip, of how to program and work with that gastric stimulator. Is there a role for centers where you have this huge team like Cleveland Clinic and Duke to actually do telementoring and teleproctoring to higher disparity areas where that community surgeon could really benefit from the feedback from either the expert motility gastroenterologist reading the manometry, or the surgeon in your case is going to guide people through how to deal with not just the intraoperative phases of intraluminal endoscopy, but also management of complications and patient follow-up.
Brian, I think that's a great question, and I think that's something like, especially SAGES being such a support of telementoring, telesurgery, that we should absolutely be promoting this for several reasons. Like, for example, you're going to be precluding a unnecessary transfer or a delay of care of the particular patient. We'll be educating that provider that more you do this, then the provider going to start doing their own and get the desire of like, I want to learn those techniques, I want to start doing those stuff. I just recently here, I was, I'm also a bariatric surgeon, and I was on backup for bariatric. And one of our general surgeons was doing a case, decided to do a exploratory laparoscopy of somebody who was a questionable internal hernia. It happens the patient had an internal hernia. And then what happened is through mentoring, telemedicine, like, of course, the same institution, right? But there's a surgeon that didn't have the cognitive knowledge to say, that's the right thing I'm doing, but had the technical skills. I was able to say, hey, this looks great. I mean, you just have to close over here. Don't do that. Also do a flex endo at the end to see if there is no distortion endoluminally. If it flows well endoluminally, you're fine. And then the patient was taken care right away, went home next day, didn't increase any cost, which was like a cell phone, So I think we should definitely be promoting this in every single one of our institutions, because as our healthcare systems grows, we all have like smaller hospitals with less resources. And if you can at least start there, I think it's a beginning.
Love it.
Yeah, I agree 100%. I think that, as we're seeing, especially new technologies, try to standardize telementoring and providing especially the hardware to do so, I'm hoping that in the next few years, we'll see a little bit more standardization where hospitals will have the ability to do this with the ease of technology. So I agree 100%.
And another thing, just to add this, and then soon we're going to start having the AI in place, right? Because everything that I did or said on the video was my interpretation of the video feed to my eyes and what they were saying, right? As we train those models, we could even tell the person there's a high assurance that if you do this, the patient will do well. Or if the model is in questioning about what's going to be the outcome, and they say, please call an expert surgeon. So I don't think we're going to be overburdened and overwhelmed with doing telementoring across the United States or the world. I think what's going to happen is, and again, this might be like a visionary, view, but it would be like in the next 5-10 years, we could have models doing some of the work triage for us and just sending towards to us experts to take over, and the model cannot do it.
Yeah. And I mean, if you look at
comment.
If you look at the impact, sorry, I just want to make one last comment.
Please.
Actually,
Please, you are.
surgeons, who are probably one of the specialties that are going to benefit the most from this technology, are lagging a little bit behind. Because if you look at, for example, what other specialties like intensive care has done, I mean, we have large hospital systems now, and we did this up in Cleveland, where you had basically a telementoring system monitoring ICUs across smaller hospitals in the region, all based in one big hub in one of the larger campuses. So I think that hopefully we're going to start seeing this trickle down into our specialty in a more standardized way in the next few years. So yeah, I agree.
While we're on the topic of artificial intelligence, I'd like to say we're working on this critical view of safety challenge, and I am one of the expert annotators. And I know, Dr. Meireles, you're a big proponent of that. What would be the benefit of having a critical view algorithm for intraluminal endoscopy as far as addressing the learning curve and preventing future complications? And for those of you that don't know, the critical view of safety challenge uses a serial video feed of multiple videos where expert annotators determine what is the critical view over 3 different criteria to train artificial intelligence to recognize that. And if we're able to help, like you talked about earlier in your talk, the segmentation of the procedure, but not just that, the segmentation and recognition of the critical myotomy plane, that could be a huge benefit for our learning curve.
Yeah, Brian, that's an excellent question. And when you talk about like the interesting thing about the acronym CVS, right? We can flip it and call critical vision in surgery, right? So it doesn't need to be just for the lap colis. It can be for whatever you're doing. The colectomy and the ureter is over there. You know, you're doing a palm and the mucosa is over there. You know, like, and think about it, like the ESD on the colon, they don't want to perforate the wall. So I think it's a fascinating topic. And I think as we explore more, like for example, the CVS challenge for lap colis is like the very first one, right? And we learned so much by building the data set, the video acquisition platform, the annotation school, the annotation curriculum. Now that we have this, framework to do this, through SAGES, we can start doing for all the other procedures. And I think we will need like champions. Let's say, for example, this committee here, I want to really look into how can we do, what's the right plane for submucosal dissection? Could be a hypothesis question right there. We get the data set, we'll do the annotation. We can extrapolate learning and knowledge, and then put up for a challenge. And more we do this, I can guarantee you 5 years from now, they're going to look at, oh, this was so rudimentary what you guys were doing back then. You know, we can actually do this so much faster. And I'm going to be so mad but happy at the same time. But but yeah, no, I think we should definitely do this. And I highly encourage projects like that. And the AI task force, which is recently was just turned into a full committee right now, so we're going to be long lasting for SAGES. One of the new missions we add will be to liaise with every single other committees at SAGES to promote AI support and development. And with the Flex Endo, I would love to do a project like that.
That's the great thing about having these webinars. We all get to be at home or in our offices and find remarkable routes for new collaborations and new projects outside the meeting.
That's right.
Any other comments from our speakers as to interest or crossover topics that should be discussed? I don't see anything in the chat box. So for those on the call, if you're interested, please submit to the chat box and I'll read the questions to our speakers. Do any of our other speakers have questions they'd like to address at this time? Well, I'd like to remind everyone to join SAGES, come to the meeting, become a candidate member, find your perfect mentor, reach out to any of us at the meeting because we love to share our knowledge or innovation and make you feel part of the SAGES family. We have a SurveyMonkey survey, and I'm extremely grateful for all of our innovative speakers and everything they've presented tonight. Thanks so much for joining us.
Thank you. Have a good night.
Brian,
Thank
for
you.
everyone.
Thanks again. Perfect meeting. Bye.